Hello and welcome everyone. Today we'll be discussing about acute bacterial meningitis. The causes of community acquired bacterial meningitis are the common pathogens being Streptococcus pneumoniae, Neisseria meningitidis, Haemophilus influenza type B. Now, the specific groups like in neonates and pregnant women, transplant patients, and older patients, you can have other organisms like Streptococcus, Suis, Listeria monocytogenes, Group B Streptococci, E. coli, and Klebsiella pneumoniae. Regarding the epidemiology and global incidence, the worldwide there has been an increase. These cases are mostly linked to the poverty levels, which is measured by the socio-demographic index or the SDI. Regarding the geographical variation, well-researched areas like there is a low incidence where the people are more well off. So it is incidence in those areas below zero point 0.5 to 1.5 per 1 lakh population. While in sub-Saharan Africa, you will find that the incidence is quite high, up to 1,000 per 1 lakh population. Regarding other African regions, you will find incidence around 2.5 to 25. So there are also seasonal and environmental factors here, like higher incidence in cooler and drier seasons. Potential impact of climate change on meningitis incidence remains unclear because we don't really have much data regarding this. Regarding the influence of epidemiology and how it has changed over the last 25 years, the widespread use of the conjugate vaccine has reduced the cases in adults and children. The HIV epidemic increased susceptibility due to the weakened immunity. The improved treatment has improved the outcomes because of the HIV. The treatment now is better with antiretroviral therapy. The prevention has been quite reduced, and advances in maternal and neonatal care has also reduced the neonatal and pneumonias. Poverty reduction has resulted in better outcomes with improved healthcare access. Regarding the role of vaccination, WHO roadmap to defeat meningitis by 2030 is going on. The vaccines for major pathogens like Streptococcus, Neisseria, and Haemophilus have greatly reduced the disease burden. Coming to the organism one by one, Streptococcus pneumoniae, it is the most common cause. It is the leading cause globally for acute bacterial meningitis. Regarding the impact of vaccination, the pneumococcal conjugate vaccine reduces the pediatric invasive pneumococcal disease significantly in the high income countries. This has resulted in herd immunity among the adults, especially in the elderly. Reduced meningitis is seen in children by 48%, while the challenges that we see is the emergence of non-vaccine serotype causing IPD and meningitis. Future vaccines are being developed. They are targeting whole capsules and proteins to address this serotype replacement. Regarding the Neisseria meningitidis, the effectiveness of the conjugate vaccine is good and it has shown dramatic success. Serogroup C, there is a sharp decline with the men C vaccine. Regarding serogroup A, it has reduced 92% in the Africa with the men Afri-Vac. The emerging challenges, though, are that epidemic caused by other serogroups is continuing in Africa, that is C, W, and X. In high-income countries, serogroup B is emerging as a leading cause of meningitis. Notable success that we have seen in the last few years is UK has introduced the Bexaro vaccine for children under 2 years in 2015, which resulted in a 75% reduction in the invasive serogroup B cases. Regarding the update of the latest vaccines that are being developed, transition from the men C to the men ACWY vaccine for teenage and adults is going on, which may further reduce the incidence of meningitis. Haemophilus influenzae, the impact is the vaccine since 1989 has reduced the pediatric meningitis by as much as 95%. It has virtually eliminated in regions with effective vaccination programs. There is a persistent concern that in patients where the poor vaccination coverage is there, that is India, Nigeria, Pakistan, there the HIV meningitis is still an important cause. And emergence of non-type B poses a new challenge as well. Regarding the global impact, HIV vaccine has reduced the meningitis case by 49% globally since 2000 to 2016. Pediatric death has reduced 90% during the same period. If we go for the group B streptococcus, it's mainly causes meningitis duodate, but can also affect older adults and young adults through contaminated fish consumption. The common serotypes are given here, which account for 98% of the human cases. Strain clonal complex 17 is highly virulent and causes 80% of the GBS disease. That is the group B streptococcus disease. The prevention strategy is maternal vaccine during pregnancy is the most promising approach to prevent the neonatal, and clinical trials are ongoing to look at its effectiveness. Regarding the pathophysiology, as this diagram here shows the model of blood-brain barrier environment during the acute bacterial meningitis. First, we must see how the bacteria is entering the acute bacterial meningitis pathogen. This is the shown here as the ABM pathogen. It is able to enter transcellularly as well as paracellularly. Alternatively, as you can see, through the neutrophil infiltration also they can enter. This is called the Trojan horse strategy. Regarding the recognition inside the brain, you have the pathogen associated factors, the PAMs, and this PAM triggers the microglia, macrophages, astrocytes, and pericytes. These are all trying to fight the infections. These cells release what is called as the DAMPs, or the damage associated molecular pattern, which influences a strong inflammatory response. So these are all the inflammatory cells which are releasing all their inflammatory responses, and this will result in a inflammatory damage, breakdown of the blood-brain barrier, and increased cerebral pressure and edema. The clinical consequence is that if the inflammation doesn't go down, it can lead to severe cerebral edema and death. Regarding the inflammation and the tissue damage that is seen in acute bacterial meningitis, one of the important thing is the bacterial replication and the immune response. Bacteria multiply rapidly in immune privileged CNS and release the PAMPs. These PAMPs bind to the toll-like receptors and trigger the release of the damage associated molecular pattern through the NF-κ beta. Now the inflammatory cascade is started, which release of the cytokines and the chemokines, recruiting neutrophils into the CSF. Neutrophils are key to bacterial clearance but also cause tissue damage. Neutrophil extracellular traps, that is the nets, they impair the bacterial clearance and exacerbate the inflammation. The release of harmful molecules result in further brain damage. Regarding the bacterial virulence factors, they have toxins themselves which can damage the cells directly. That is the pneumolysine, which is a toxin damages the blood-brain barrier and the hippocampal cells. The capsule reduces motility and the chemostasis of the microglia, and the RAGE activation, which increases the TNF alpha levels, promoting blood-brain disruption. Also, the host immune response can be important for clearance as well as for the damage, because it can lead to dysfunction of the coagulation, the fibrinolytic pathway, leakage of the vessels, more cerebral edema, and this can lead to death as well. Regarding the clinical insight, as you can see that inflammation is a very important thing. Decreasing this inflammation is going to be life-saving. So dexamethasone therapy reduces this inflammation by inhibiting the NF-kappa beta and cytokine release, and improves the outcome in Haemophilus B as well as pneumococcal meningitis. Now, if we look at new insights that we're getting from the genomics and proteomics regarding the bacterial genomic studies, the GAUS, this is the genomic-wide association studies, has revealed the bacterial genes involved in the tissue-specific targeting, neutrophil recruitment, strain-dependent bacterial clearance. Key findings regarding Streptococcus pneumoniae, the genes like RAF, operon, and proteins such as elongation factor tau are linked with the bacterial tropism, that is preference to particular sites for infection, severity of the infection, as well as murine studies have found contributors to the pathogenesis. The human pathogen interaction studies have been done, which has shown that host genetics plays a critical role in disease susceptibility and severity. Examples, variants in the CCDC gene are associated with disease outcomes. CCDC3 regulates the inflammation by suppressing the inflammatory markers in the endothelial cells. The clinical application over here is that we are trying to emerge therapies that are targeting these virulence mechanisms and modulating the host responses. And in future, diagnostics can predict the disease severity of a host and the bacterial genetic profile as well. Now, if we look at how do we manage and diagnose this disease, coming to the diagnostic, it is clinical. Obviously, you must have fever, headache, neck stiffness, alternate mental state. The clinical triad of fever, neck stiffness, and alternate mental state has limited sensitivity, but a high clinical suspicion is definitely required. You do the LP, essential for the diagnosis should be performed before antibiotic to avoid sterilization of the CSF. Delay in the LP, example in case of brain imaging, reduces the diagnostic yield and worsens the outcome. Regarding the brain imaging, it is recommended only for patients who have focal neurological signs, GCS less than 12, seizures, shock, or coagulopathy. Other than this, you should go for the CSF analysis. In the CSF analysis, you will find elevated leukocyte count, which is most predictive marker. PCR testing can be done for the common factors. Larger brain can also be used. Next-gen sequencing has been showing positive outcomes. And antibiotic administration should be done immediately. Choice is based on local resistance pattern, that is Streptococcus pneumoniae resistance. If it is around 15 to 20%, then you go for the ceftriaxone and vancomycin. Regarding the adjunctive therapies, as we have already discussed, dexamethasone is important. It reduces the inflammation, improves outcome. Ineffective in most low income settings except for Streptococcus suis meningitis in the Southeast Asia. Ineffective treatments should be avoided, that is hypothermia, glycerol, they have not to be shown of any benefit. And we have to look for newer therapies that we have already discussed. Regarding emerging therapies, daptomycin, it is in phase 2 trial. It is a non-lytic antibiotic that reduces inflammation and causes by the bacterial lysis. Complement 5 inhibitors, they target excessive coagulation and fibrinolysis in the CSF and has shown positive results in animal models. You have newer targets like DNase 1, which disrupts and harmful nets. Then you have the matrix metalloproteinase inhibitors, which prevent the tissue breakdown. You have neuroprotective agents like metformin, which are still under clinical evaluation. The clinical insight is early intervention is important. Do a early LP, prompt antibiotics should be given, but keep in mind where you cannot do the LP and you do imaging previously. Challenges are delay in the emergency department where the time is spent without giving the antibiotics and imagings are done. Regarding the antibiotic choice, go with the third generation cephalosporin like ceftriaxone as your first line, but research is exploring bacteriostatic alternatives to reduce the inflammation. Thank you for your patience.